Okay, I'll get started. Afternoon, everyone. I'm Jim Mackey, the Medical Director for Patient Safety at the CEC, and I'm presenting here today with Debbie Draby from the CEC. I'd like to begin by acknowledging the traditional owners of the lands that we're meeting on today, and I know we're meeting on many different lands from all over New South Wales, and I pay my respects to elders past. Present and emerging. I do want to acknowledge it's on their lands that we're meeting today. Today, we're going to be talking about safety intelligence and really data-driven morbidity and mortality meetings, and just kind of thinking about morbidity and mortality meetings in a different way. I'm not suggesting we throw away, single case discussions in M&M meetings. These are very, very useful, but I think you can make your M&M meetings more perhaps interesting and more powerful in terms of understanding where we're going with improving patient care and getting the best out of our M&Ms by using some data. And the QIDS system can help you with data for those meetings if you want to think of it in that way. So we're going to divide this talk into a couple of segments. Firstly, will be Debbie's going to talk about the M&M guidelines and the principles around those and how they support M&M meetings, and then I'll go through some data opportunities to show you how you can think about data for use in M&M meetings. And then we'll leave plenty of time for questions at the end. So I'll hand over to Debbie now to talk around the M&M guidelines. Thanks, Deb.
Introduction, Jim. So as Jim mentioned, I'm just going to briefly spend the next 10 minutes talking about our M&M guidelines, which we've recently updated, and just to talk to you a little bit about the content of that update and what's really driven some of the sort of motivation to bringing the guidelines up to contemporary safety and quality principles, and they're very much guided by human factors with a focus on enhancing learning and system improvement. So I'll just give you a bit of a rundown. Sorry, Jim, if you can move to the next slide in relation to the context of the new and updated guidelines. If you've not seen them yet, underpinned by 6 guiding principles. Today we'll be focusing predominantly on, we're talking about all of them, but predominant focus is around meeting framework, and particularly in the context of safety intelligence and the importance of using data-driven decision making to help support, what some of the agenda is and the themes and topics that may be discussed at M&Ms. So the conversations are meaningful but supported by data to really give a sense of what the themes are and what the core issues that may be presenting when we're looking at reviewing care. So, and Jim's going to launch into a really good example of the QIDS system and how it can be best used to support and engage the data needed for enhancing M&M discussions. But I do want to touch on briefly the other core principles, guiding principles that underpin M&Ms. First one being around safety and ensuring that it is a safe space for learning. And again, today we're talking about data, how we engage data in a safe and meaningful way. And we know often there can be challenges around, exploring creating a safe space, what are the sources of the data, particularly when we're looking at trends and variation and so on. Where is that come from and how is it understood? And thinking about that in a for the purpose of learning rather than seeing the data as a judgment tool as such. So that's a really critical thing when we look at safe space for learning. The second principle is around the importance of multidisciplinary conversation. We know when we're reviewing our care more and more in the literature, that's really critical that care is reviewed from multidisciplinary perspectives, because that's that's in essence how care is delivered. We think about the models of care we're working from. It's important in that review that the various perspectives across the disciplines is considered, and thinking about that rather than just focusing from one discipline or one craft group and so on, because we know that we have richer conversations when we look at it from different perspectives. So as I mentioned, we'll focus today on meeting framework and systematic agenda selection, and also the importance of a guiding principle number 4 is around supporting comprehensive discussions, and looking at when care is reviewed, the conversations that happen, how they're facilitated in a safe and meaningful way, where there is really good facilitation to ensure that people are able to participate and contribute their experience, particularly when we're looking more and more from a systems perspective rather than looking at individuals. And we know underpinning all the guiding principles, the importance of reviewing care from that systems perspective, rather than looking at how individuals, what they did and didn't do and so on. That can be quite linear and limit our perspective and our learning. So how that conversation from a systems perspective is facilitated is really critical. And then moving on to consolidating the lessons learned, and a core principle around being able to document the key learning from our discussions and reviews at M&Ms, and then documenting them in a meaningful way and being able to share them to the system. So those really critical conversations and learning is informing system improvement and so on. And finally, the principle around governance and ensuring that there are clear pathways to support learning and recommendations, and looking at the importance of that communication across the various governance pathways that we have within the system. So M&Ms are not just seen as something separate, but they're very much integrated into our governance structures. So just in terms of supporting and implementation of the guiding principles, a really key theme that's come up in our conversations, I should have mentioned earlier, sorry, the guiding principles within the guidelines have been formulated in consultation with a statewide advisory group, and we're very much talking about some of the challenges and formulating an implementation plan to support implementing the guidelines and each of the principles. And a key theme that keeps coming up are the challenges around leadership of M&Ms and cultural factors that can impact on implementation, particularly in the context of a culture of safety, and around enhancing conversations for learning. And we talk more and more around the importance of just culture and the importance of reviewing for learning, not for judgment, and how we can best access data to support those conversations. So definitely a key theme in the implementation is around supporting and enhancing the leadership and culture, and how that can best improve M&M conversations. So just on the next slide, Jim, I've used, one of the practical strategies, we're trying to develop more and more resources and tools to support and enhance the guidelines in implementation. And one of the things that we're doing is obviously this webinar series is a good example, but we're also generating a podcast series. And I've started to record some conversations with clinicians around their experiences of M&Ms. And some key things that are coming up when we're looking at exploring leadership and culture. A key one is around psychological safety and how we enable a safe space for open discussions where clinicians feel, often opening up and talking about their experience of care, and when that care is being reviewed, it takes a lot of interpersonal risk to, to share, and to, be open about how care is experienced, and what some of the challenges have been for them personally, but also as a team. So more and more a key theme is around, ensuring that psychological safety. So our clinicians' voices are enabled and we're able to hear the different perspectives. And a critical part in that is facilitation, which I mentioned earlier, and the importance of core facilitation skills to help engage the voices and the experiences in the room, because often a case is being presented and I'm sure there is a familiarity of that experience as someone, a clinician, is leading the discussion, and there may be clinicians in the room that share exactly that experience, and how do we engage that conversation and people can contribute their perspective in a safe way without feeling judged or feeling that they're being scrutinized in any way. An important part of that is a good M&M meeting is one that's prepared well, there are no surprises necessarily. Clinicians are aware of what the agenda is, the cases are selected in a meaningful way, and Jim's going to talk about an example of that using analytics. Also, a challenge in terms of the leadership and the culture is around the power dynamics. In any group dynamic, in a clinical meeting where cases are being reviewed, there is a power dynamic and a hierarchy, which can impact on people's capacity to contribute. So again, these are some of the core things to think about when we're looking at implementing some of these guiding principles, and how, and Jim will now talk briefly about, how we can use data and the data systems that we have in QIDS to support that. And also in terms of engaging that interprofessional learning and sharing experiences. I do have a final slide there around that leadership and culture in terms of systematic agenda setting guided by analytics, where we're able to identify themes, trends, and that way the data can inform the conversation, and look at maximizing learning opportunities when we have an evidence base there of what some of those trends may be, not just based on people's perceptions necessarily. It is guided by an evidence base and a data source that everybody is growing familiar with and is able to engage in that conversation. And also looking at, once those conversations happen and there's some key learning, how to then generate some actions to better support improvement within the system. So there's some of the key themes that are emerging within the guiding principles and some of the challenges that we're looking at in terms of supporting implementation. So I'll move on to Jim now to launch into a conversation about QIDS and looking at the guidance. There's just a couple of slides there if you want to look at later. That'll be in our slide deck, which we post up around some of the screenshots from the system.
I wanted to talk a bit about how M&M meetings, the kinds of things that we can discuss in an M&M meetings. And now I've been to a lot of M&M meetings over the years, and we obviously mostly discuss patients who died, or other times we discussed other predefined criteria for patients to talk about. And some of those criteria might be unscheduled admissions to intensive care, or some people unscheduled readmissions after a couple of days, or unscheduled returns to the operating theatre have been traditional ways that people have looked at those other than deaths and I guess other complications. In my last clinical department, we also had a criteria that any member of the team, and by that I meant the multidisciplinary team, could nominate a patient for any reason for discussion. And there would be many ways that you might generate that. But I also want you to think about some other possibilities, and particularly now as data becomes more and more available for clinical teams, to think about whether clinical incidents that are reported through your, what used to be IMS system, or now IMS Plus. You could think about your hospital-acquired complications. There's a lot of focus on hospital-acquired complications for many reasons. These are harm events that that affect patients' care significantly. We know that people who have those kind of complications stay in hospital longer and have worse experience. Patient experience data is another important piece of information, and collective patient experience data might be worth discussing at an M&M meeting to get a sense of how your department is travelling. There's also things from clinical pathways. I think a great example of this is in surgical services around perioperative antibiotic timing audits. There's a lot of evidence that the timing of the dose of antibiotics for procedures that need antibiotic cover, and then making sure that redosing during long procedures happens at the right times makes a difference to the post-operative complications for these patients. So this is an audit pathway that might be worth discussing in M&M meetings, and there are obviously many others. Other data like hand hygiene data from that's available for all kind of craft groups, again through QIDS and other things. It's available. Hand hygiene audits are done in every facility, and there's no reason across New South Wales, and there's no reason why that kind of data. We know that data affects outcomes particularly for infection-related complications. Why not have a look at that from time to time in your M&M meetings? There's some new capability in QIDS, which we hope senior clinicians, senior medical practitioners will share. And so these are for the admitting officers. They're able to get specific data related to hacks or other criteria for patients under their care. Now, this data is only available to them, but we are hoping senior medical practitioners will share that data with their colleagues, with their team, and so they can review it in M&M meetings. There are many more options. I could talk a lot. What I want to show you now is how easy it is to really get data, and to know how good you are today, and to know a bit about where your waste and unwarranted clinical variation and harm is, and how you're comparing to the best in class or others in the same class. But most important is that whether the data that you're seeing is showing that your service is improving over time. We want to talk about data for improvement, not judgment. We're not out to show somebody's bad or somebody's good. We want to show that everybody is getting better all the time. That's the real aim of this. And this is where QIDS can help us, providing you with data for improvement. It provides you with a meeting management module where you can record action items, and you can also run improvement projects in the QIDS module. And I'm not going to go into the QIDS module a great deal at all today, but I just want to highlight some of the data that's available. I've already mentioned some of this, IMS and IMS Plus. The IMS Plus data is currently incomplete, but hopefully we'll have it soon when the provider is able to get it all to us. The healthcare acquired complications are certainly available. The only difficulty with those complications is that we don't get that information until the record's coded, which might be 4 to 6 weeks after discharge. But still, no reason not to look at it in a department to see how you're tracking. And as I mentioned before, the specific hack conditions for SMOs and other procedures are available. For the ED departments, I think there's lots of information there that can be used to select cases or themes for M&M meetings, including patients that return to the emergency department and require, say, admission to intensive care. That's easily, or patients who return to the ED and die. They're often patients with chronic illness, but they're occasionally things that we miss and we can learn from. Things like in-hospital mortality and length of stay, hospital-acquired infection data, as I mentioned, hand hygiene. And I want to show you a little about some really exciting data that's going to be available for maternity services in the near future a little bit later on. I'm not going to spend a lot of time on QIDS today in terms of how it operates, but this is just an overall view of how a dashboard like this. This is my very configurable. This is my dashboards. That you can configure your own, and these depending on what you need. And these are your kind of your data sources in QIDS. And as I say, we'll deal with that in other meetings. Now, I have given a seminar, a webinar recently on the M&M meeting module, and we're not going to cover that today. This is just how it kind of looks. It's been recorded, and you can see how that how you operate the meeting module. But just a reminder that webinar is available. And I just want to stress, I guess, when you're working in morbidity and mortality meetings, the importance of trying to get data into a meaningful place. And so if you're looking for a data, how your M&M meetings are function, if you can use a system, and there's one in the system already in the system called DEX, but you can design your own, that's fine as well, and we can arrange for those forms to be available for you to allow you to classify things that you're seeing, so you can see if count over time problems that you're encountering, so you can see where your efforts to improvement are, because you can put a lot of effort into a single patient episode, but if there are lots more things happening, more or events happening that are more frequent, it might be better to spend your improvement time on more frequent episodes rather than the less common ones. And this is where data for M&M really starts to help. And I just wanted to remind you about the Australian Commission's HACs, healthcare acquired complications. I'm sure you're all pretty familiar with these. There are 16 of them. Electronically there are 14 available. HACs 4 and 5, surgical complications requiring an unplanned return to the operating theatre and unplanned intensive care admissions. There's no electronic data available, unfortunately, but all of the other HACs are available in many systems, including QIDS. And as you know, they're used for performance assessment of the hospitals and the LHDs with the ministry, but also for funding. And so, reducing HACs is worthwhile in a number of ways. And this is just to show you how well New South Wales has been going. And this is New South Wales data over 5 years, and we can see here. This is a process control chart. This is an average line in the middle, and these are the upper and lower control limits. And we go back to July 2015, and we had peaks in activity, or peaks of HAC events, and these actually HAC events corresponded with winter flu seasons, with the very bad one of 2017. And then after that, we've had continual improvement, because this is the time that New South Wales Health really started to focus on HACs. Because the federal government introduced funding penalties, was one of the drivers for it. But this has been an important driver of improving care. And if you look at what's happened over that time, over the subsequent couple of years, have been tremendous improvement across New South Wales in reducing the number of HACs. And the whole system should be really proud of themselves, for they've made a really meaningful difference to harm events in hospital. This is a really interesting kind of just statistical quirk, really, and this is this is a rate per 1,000 separations, and you see this sudden peak here in the middle of COVID last year. And of course, you first think what's happening here, but of course, as I'm sure most people on this call will recall, at that time in April, May, there was virtually no elective work going on in hospitals, and the numbers of patients in hospitals were significantly reduced. Only the sickest patients who were more prone to complications were in hospital, and thus we see an increase in the rate. In the QIDS system, you can generate this yourself and see it. You can see it for your own hospital or your own LHD, and you can also change the to account. And you'll notice that although the rate was very high, this was actually quite a low number of hack events, reflecting the decreased activity at that time. It's just the higher risk patient group were being affected. I think this. I just want to remind you here, this average line that I pointed out on the hack rate runs for that 5-6 year period about 28 per thousand separations. That's about 2.8% of all patients in hospital have a hospital-acquired complication. But if you come into hospital with diabetes, that rate goes up to over 60. If I was to, and it's very easily to do this in QIDS by just putting a diagnosis of diabetes in there. So this would be a comorbidity. So any procedure, so anybody who comes into hospital with diabetes is twice as likely to have a healthcare-acquired complication. So that's immediately a way to say, gee, this is a higher risk group and we should be focusing some of our efforts. Of course, if I was to show you a graph by putting those diabetics in and changing this to just patients over 70 years of age, we'd almost triple the rate of hacks. So it's a way of stratifying risk and looking at those patient groups that might be worthy of attention. Likewise, looking at your own hospital. And now this has been de-identified, and this is an A1 hospital in New South Wales, and this is their hack rate over 5 years. And you could see the dark green line that this hospital, and it sits there, and the gold line is the A1 peer group. These are major teaching hospitals, and clearly this hospital differs from its A1 peer group. Now that's not necessarily a bad or good thing, but it's worthy of investigation. And I know this hospital has investigated it, and you can see this is actually charts only up to August. I probably should have updated it for you today, but it's just an older slide. That trend has continued. This hospital has been doing a lot of work in this and reducing that hack rate, and they've been using QIDS to identify some of the things that are driving that by drilling down to individual cases and seeing what the actual hacks were. The other thing, of course, is often when I show clinicians this data, they usually say the data is wrong. And one of the useful things, but if you've got drill down access in QIDS, you can get down to individual patient records and you can check the actual coding of the patient if you know what happened. If you disagree with the coding, you can talk to your coders and get it recoded. And if the coders recode it the next week when we get this data, that data point will change for you. And if you drill down, this is the kind of information you get. That's by left clicking on one of those data points, and you'll see used to be, and we've de-identified this, but there's a number of patients been identified here. And you can see the types of complications like healthcare associated infection or delirium or cardiac complications. And you can click on this little button here on the right hand side to drill down to that individual patient record, and so you can check all of their patient identifying information, the details of the wards, everything, the various diagnoses, and if you have looked down the bottom, you'll see the procedures they've had, and this person's had a lot of procedures over time. And you can see down the bottom here, there's a little button, add to your M&M list. So if you're using the M&M module in this, and you've identified a patient like this through your data, you can take all this information directly to your M&M meeting without having to do anything more other than click that button. I think there's some really interesting trends in data across New South Wales. I've already showed you the really big improvements that we've made in hacks, but I just wanted to highlight the one hack, that's actually increasing. And if you're looking now, we now deal with hack version 3 from the Australian Commission. It came into play in July last year, and you can select in QIDS which version you're using, but the current version used by the Commission is version 3, and that's the version that the Ministry uses for performance agreements. And you can see that endocrine conditions have risen across New South Wales. And endocrine conditions, this slide's wrongly titled, but it's hypoglycemia is the thing that's risen over the last number of years, and it used to be a medication complication. It used to be in HAC version 2, but it's been moved to HAC number 13 by the Australian Commission, because a lot of these hypoglycemic events are not related to diabetes-related medications. They're related to nutritional episodes as well. And remember, this is a serious problem. At the CEC each year, we see people who have serious brain injury and death from hypoglycemia. So this rising trend in hypoglycemia across New South Wales, and it's the only complication that's actually rising, is worthy of intention to say. This is from version 2. It's the same data basically, and and then moving on to looking at other medication complications like psychotropic medications. I was then going to go and highlight things like mental health conditions, and looking at, for instance, at HACs and people with specific mental health conditions. And so, even people with, for instance, a diagnosis of a mood disorder, which is, and not necessarily in mental health facilities. This is people in just as much in regular medical and surgical wards. Those people with those kind of comorbidities, a diagnosis of a mood disorder or schizophrenia, have a much higher rate of complications. And even if you have a mood disorder and diabetes together, you can have a look at the slides when you get the pack. You'll see that the rate of HACs in that group is around 14% of all patients with diabetes and a mood disorder, like a bipolar disorder or a depressive disorder, will have some form of in-hospital complication. Likewise, schizophrenia and diabetes, about 10% of those will have it. If you go into surgery, if you look at specific operations, and the example that I had for you was a common operation across New South Wales, which is a laparoscopic cholecystectomy, where there are about 850 of those done every month across New South Wales. So it's a high volume, kind of fairly low risk surgery. And if you look at it, about 2% of people having a laparoscopic cholecystectomy have a hospital-acquired, healthcare acquired complication. Which is lower than the overall rate of HACs. But if you have diabetes and a laparoscopic cholecystectomy, then you'll have a rate that's more than double that. And if you're over 69 years and have a laparoscopic of age and have a laparoscopic cholecystectomy in the presence of diabetes, your complication rate goes up to 7.8%. So here's a high risk group to be kind of looking at and seeing what you can do to improve that. And again, if you want to see how your facility is going, there's a report, what's called a multi-locations report, where you can see where your hospital sits against its peer hospitals in New South Wales. And so you could see and if you could see the slides, you'd be able to see multiple bar charts of then they've been de-identified, but they show the different rates of HACs for a cholecystectomy by different LHD or by different facilities across New South Wales. And if you're looking at this in your own facility, you'd see your own facility in blue, and you'd see grey lines. You wouldn't be identified which were the other facilities, but you'd see where you sat with other facilities across New South Wales in terms of that. There's some other work which we're doing, and some proof of concept work, and which will be available, we hope, soon to show you what kinds of things we can do with triangulating data, and that's kind of using multiple data sources all at once to identify, kind of smoke signals for potential harm events, and that would be particularly in the emergency department in the first instance. And then I can move on to the new data, which we hope will be available in the next month or so, and this will be near real real-time data about maternity, and we are hoping that this data will be available up to date as to the day before. And so with this data, you'd be able to track your indicators for poor maternal and neonatal outcomes. For instance, knowing your time from decision to need an urgent cesarean section, the most urgent code 1 cesarean section, the benchmark is for good care is around 45 minutes. But with these reports, you can track the number of patients in your facility or your LHD where the code 1 cesarean section time exceeds 45 minutes. And you can also track preterm delivery rates. Again, another risk factor for poor neonatal outcomes, and also things like APGARs at 7 minutes, and also the effect of BMI on cesarean section, and many other factors. But this data is going to be not available yet, but will be available. We're just finishing the proof of concept work and commencing to get the data from all of the facilities on Maternity in the first instance. That's going to be 13 LHDs, and then the 2 LHDs that use Cerner Maternity will be following up soon after with that data. So that were the kind of data. I'm really sorry about the internet falling out in my house, but that's just what's happened. I wanted to stress how you can use these, your own circumstances in your own departments and own hospitals is what drives this, and understanding your local data and your multidisciplinary teams in your M&M meetings can use data to understand the problems you got, to stratify the risks, and more importantly, use validated improvement methods and work on what you're going to do and measure your improvement over time, so you can actually see that you've made a difference when you've done that made those interventions. I hope that's helpful. Again, sorry about the technical failure. But I'm happy to take any questions, and as I say, we'll be able to distribute the slides to make it possible for you to look again, and I can obviously answer questions, and maybe we can even do this again if that's of help. So thanks everybody.
Thank you.
Does anyone have any questions that they'd like to ask?
Silence is golden.
Yeah.
Actually, I will ask a question. I work at a service that is an outpatient therapy service. Is it possible to enter information that's very service specific? Can you set up, I guess, collection of data on literally any subject?
The trouble is we don't have non-admitted patient data in QIDS at the present time.
Okay.
Available to you. If you do have data, there are ways that you can connect QIDS up to look at that data, but you need some technical people to do that.
Right. Okay.
We do want to try and get as much of that relevant data as possible, but at the moment we don't have, except for the ED department, we don't have any other non-admitted data. I'm sorry.
Not at all. We are collecting our own data, but I was just wondering if there was some kind of cross usage there. Thank you. You've answered my question.
Any other questions?
Hi James, this is from the NICU at the Royal. And there are quite a few committees within each department, isn't it? Like a quality committee, then you have the morbidity committee, then you have a separate, like something called like a trigger committee, or like looking at the adverse committee events. It's just that like many of them, when look at the similar sort of issues. And the way that we have been working on is that within my department, for example, mortality morbidity meeting, we discuss individual case and we see any lessons that we can learn from that individual case. But if there are any system issues that are seen in consistently in other cases, then they move on to the quality committee to review that and take it up as a quality improvement project. Is that how, like, is that still something,
Look, I got to say, I don't think there are any rules around this.
Yeah.
I think you've got to do things what works for your institution. The only thing that I was trying to kind of get across to people is that an M&M meeting across the system can be a valuable place to learn about things and to identify genuine patient safety problems, and how you deal with that's another thing. But I mean, I think clinicians, at the front line, see their problems, and particularly when they see the data, can understand it better often than people who aren't close to the patient. So when you see a run of something happening in your data, and the patients, this is you identify things that I don't think the system overviewers identify as quickly. And that's why I kind of why I stressed looking at this. But it doesn't have to, as I say, I'm not trying to prescribe that at all. This is just what works for your institution. If that's working, that's great. But it's I'm just trying to open the eyes that you can think about M&M meetings. You don't have to die to be discussed at an M&M meeting and there's a lot to learn from other things other than just patient deaths to improve service quality.
Yep. Thank you.
I had a question here from Marcia Pankhurst around, can we get specific data for Sydney, Southeastern Sydney OHD mental health service hacks associated with SMI, such as high BMI, diabetes, and polypharmacy rates for antipsychotics, etc.?
You can do some of that. I mean, the data is polypharmacy. We don't have data on. This is it. Whatever's available in the coded information is available to you, and you can do that by service groups and look specifically at mental health services. So we don't have at the present, except for what's going to be coming in maternity. We don't have direct EMR data. It's only the coded data. So if it's in the coded data, yes, you can get it from QIDS. But if it's not in the coded data, but you can obviously also marry that up with incident data that's reported. And although we don't, we're hoping that Datex will, the provider of IMS Plus, will be able to provide us with more granular data soon, so you'll be able to see those reported incidents in QIDS more clearly, and be able to put that alongside other data like hacks, etc., to kind of get an overall view of how your particular service is running, to develop triangulated kind of views of things. Hope that's helpful.
Thanks so much, Jim. Thanks for your persistence and for sharing. That's really useful.